and weight reduction, because with the anabolic curve that you were talking about earlier, unfortunately, there have been factors in the environment which has set people up into a state of hyperinsulinemia, which has created an excessive amount of storage. So I'll let you kind of take off.
Okay. Well, one of the things is I've written some stuff and I handed out to our patients at my clinic that there's been a paradigm shift in the practice of healthcare, and it's away from the focus of reactive pathology-driven disease management to a new focus of proactive, causation-focused, true health management. And the only way you can do that, because the system that evolved out of the late 1800s and 1900s was focused on having to find out who had invaded us and then develop a plan to take care of it. But in today's world, when many of the modern day diseases, if you look at the top 10 or 15 modern day diseases, the one common denominator they all have is aging. Every one of them has a component of aging that increases the risk for developing that disorder. And that's why in longevity medicine, if we can start to evaluate organ system performance at a physiological level, are you physiologically behind or in front of your chronological curve? And obviously, for good health and youthful vitality and functionality, if you can stay physiologically at a slower rate of aging than you are chronologically, well, that lends to having a longer, healthier, more independent. That's another issue. So many people, they end up in convalescent homes or nursing homes or long-term facilities. Focus on what's happening inside your body, the causation levels, and then correct those issues before they come to the surface as an overt disease. So the difference between reactive and proactive focus in delivering healthcare services. So in longevity medicine, we have the ability now to look at the brain, the heart, the vascular tree, the lungs, the skin, the immune system, and the cell in terms of defining physiologically what their age is. And once you have that kind of information, then when you periodically reevaluate, you not only know the physiologic age, but you can determine the rate at which the aging is occurring. And that gives you lots of useful information. I mean, the Riordan Clinic already does amazingly in-depth blood work that allows us to look at essential cellular nutrients, look at biochemical components like your electrolyte balance and blood cells and hormones, and then we can use that information. We can also grade it in terms of age. So we use a grading system that's kind of like in school, A to F. And of course an F means that particular item is a lot older than it should be. An A means that it's optimal or functional and at a youthful level. And no one in conventional medicine, they look at labs and they run down and they're looking for a flag that says high or low without actually looking at, well, where does that value fall in a functional realm? Because many of the lab values are based on aging, and they clump everybody into one pool. So what do you think a vital hormone, what do you think the bottom of the reference range represents? It represents elderly people that have lost all endocrine production of essential hormones. And those at the high end are young at their peak production. So the way you look at labs and then apply that to symptoms and complaints the patient may be having, and then looking at the physiology inside your body, it's kind of a new approach. And the goal is to try to slow or reverse a lot of these ages of diseases of modern day that are highly correlated to the aging process. because you start losing things that kept you healthy and functional and disease-free. I mean, your immune system ages just like everything else, and it loses its ability to protect you. It's like you're losing your armed forces, and now you're vulnerable. That's why elderly people die much easier of influenza and pneumonia than younger people. The young ones have very powerful military forces that can take on the insult and conquer the foe, so to speak.
So we're not waiting until we get sick. We're going to the doctor, in this case, the anti-aging specialist, functional medicine specialist, integrative medicine. There's all kinds of new names that are cropping up as we enter into this newer paradigm of care. And so, how do you encourage people to start thinking about themselves differently than maybe in the past, where we're going to wait until a symptom emerges?
Well, I mean, one, being proactive. I mean, when I, more than 30 years ago, I opened a center that was called Life Center here in town, and a life improvement through education and fitness, nutrition, and starting to take a look at the things that we do to ourselves or the things that we don't engage in can have deteriorous effects on how we end up. And so lifestyle and health risk behaviors, environmental considerations. The reason I focus a lot on weight loss, you can't really practice longevity medicine if you don't include the issues about how the body's composition is put together. And that means, how much fat weight, how much water weight, how much muscle weight, how much visceral fat distribution around the belly, because it's the more metabolically and harmful, because it produces hormones of its own that don't do good things in the body. So I think a better understanding that if I'm going to stay healthy and live a long time, I have to make an investment in it and be proactive about it, not sit back like the conventional medical focus has been, is wait and react when the pathology is already there. When if you proactively do things in your own health and defense. And one of the ways is aligning with somebody that actually does what we're talking about here, so where you can be evaluated and your blood's looked at from a different perspective, not just, do you have some disease? It's looking at the functionality of the blood component. And the same thing with including like body composition, to look at healthy fat versus unhealthy fat and distribution, and then lean versus fat ratios and that sort of thing.
So let's kind of get into a discussion about this because I think not everyone, but 70% of Americans are struggling with their weight now. So it is a problem. It's a problem that's an obvious problem, but it doesn't have an obvious solution. And we can talk a little bit about the trend has been exponentially high in the last 30 years. And one of the little thought experiments I have people do is, I don't know how old everyone is here in the room, but I know back when I was in grade school and high school, people struggling with weight was not that big of an issue. It was people had the problem, but it seemed to be more of an isolated problem. Now it appears to be more of a universal problem. Even people who are not overweight are still feeling like they have to watch what they eat. And so just from your perspective, Mike, what do you think are some of the antecedents that kind of have led us into this situation to where so many people have so much trouble controlling their weight? Because it clearly does associate with increased risk for various illnesses.
Here's kind of an interesting, in 1948, when cardiovascular disease was starting to become epidemic, the government hired a panel. Hired a panel to come up with the reason for this accelerated growth rate in vascular disease and death from cardiovascular disease. And the guy they hired was named Ansel Keys. He was a PhD, and he and his group did a complete analysis and came back to the government and said, the reason why cardiovascular disease is becoming so rampant is because of fat and cholesterol. And you need to set up a campaign and get everybody off of fat and cholesterol and go to a high carbohydrate diet. So then if you hop forward 50 years from 1948 to almost 2000, what's still the number one cause of death and disease? It's cardiovascular disease. And what happened to this concept with go to a high carbohydrate diet and get away from fats and cholesterol? Well, epidemic onset of obesity, that high carbohydrate diet just don't work well for maintaining weight. And the other thing is, the drug companies went to bat and developed all these statin drugs to lower cholesterol. And even though we get real low cholesterol levels, we seem to still have a lot of vascular insult that leads to heart attacks and strokes and other things. So I think that that whole process, when the government launched this huge campaign that went for years, that you got to get away from fat and cholesterol and focus more on carbohydrates, has been a big contender in why we're at where we're at. Now, I'm not saying that's the only thing. A lot of kids and younger people are sedentary, and they sit in front of the TV or they play with their, like my grandkids do, the iPads and stuff and all the games. I mean, the activity levels are not the same either.
And yet, it's been shown that in the last 20 years, eat less, exercise more, mainly go on a diet and get more exercise. It can help people lose weight. But if we look at one of the shows that's highlighted that approach, The Biggest Loser, that show does not have reunions, because the people that lose the weight just by eat less and exercise more seem to gain it back. And so dieting per se has somewhat failed in our effort to get control of this one component of the modern epidemic of chronic illness, namely obesity. And the new term is diabesity, because as you gain body fat, you increase your insulin resistance. And as insulin resistance goes up, then you are becoming more and more diabetic. And then a lot of the diseases that go along with obesity are actually related to the insulin resistance problem that's associated with fat gain. So it seems to me what we've kind of been looking for is a way not just to lose weight, but to lose fat, lose the right kind of fat, so that we don't keep having this insulin resistance, which sets people up for hypertension, for inflammation, autoimmune disease, leaky gut. Even mood disorders have been associated. Most of the serotonin that the body makes is made in the gut, and so mood disorders may even be related to these states, and hypoglycemia issues as well. So I thought what we might do is talk a little bit about the other part of what Mike is doing here at the Riordan Clinic, is helping people with a medically supervised weight loss program. And I'm just wondering, how did you get into that, and where has that taken you in these last few years?
Well, it's like I was saying a little earlier, it's kind of
Yeah,
hard
use
to practice.
your mic.
Can you hear now?
Now,
Okay.
yeah.
It's kind of hard to practice longevity medicine if you don't address the issues around weight. So when I started out, there was no way to get around it, because weight issues create problems with not only the joints and the skeletal system, but metabolically set you up to develop diabetes that can contribute to hypertension and accelerated plaque development in the endothelial lining of the vascular tree. So it's kind of like out of necessity. If you don't address the issues around dietary intake and whether a person is able to maintain a more ideal weight rather than accumulating a lot of excess weight, is kind of a cornerstone, along with assessing health risk, other health kind of risk, and lifestyle risk. The weight issue is pretty important because it also affects a lot of the blood components. Especially like I don't like triglycerides. I have backed off some on cholesterol, unless it's a familiar type genetic trait. But most of those people have outrageous, cholesterol in the 350, 400 levels, and LDLs of 250. But most people don't have that. So I like to focus on triglycerides because they are pro-inflammatory, and they increase the viscosity of the blood, and if they're not burned up, then they get stored inside fat cells for future energy use, which is basically adipose tissue is filled cells with triglycerides.
Well, we've kind of found out that adipose cells have become another endocrine organ, that they are releasing leptin and ghrelin and other inflammatory hormones that impact the system in a negative way that set people up for failure in the effort to lose weight. But I thought we might talk a little bit about Dr. Simeon's. And it's interesting that here we're seeing that obesity is a hormonal problem in essence, but is there potentially a hormonal solution in terms of what Dr. Simeon's was able to find early on? And I've got a slide up about him, but I'll let you go ahead and talk a little bit about him, Mike.
Okay, well, Dr. Simeon's was a British-trained physician that ended up setting up a really large weight loss clinic in Rome. And he had started out working with young, considerably overweight boys, and was using HCG, chorionic gonadotropin, to treat their gonadal deficiency. And in the midst of doing that, he started noticing that many of them started losing weight. So he kind of advanced on a theory and ended up putting together that maybe HCG has an effect on a primitive part of the brain called the diencephalon that's back behind the hypothalamus, and that in starvation mode triggers off release of stored energy out of fat cells and tissue. And that's where he came up with the use of injections of HCG and going to a near starvation calorie level of 500 calories a day. And he wrote this thesis that's called Pound and Inches, and it was presented to the American medical side of things, but he wasn't well received in this country because the medical establishment just felt like it was too dangerous, and 500 calories was too low of a calorie intake to do it. But in many cultures, intermittent and periodic fasting, I mean, that's kind of like a starvation type thing. So he had a lot of success. I mean, he wrote that Pound and Inches and said that you could lose a pound a day over 30 days, 30 pounds a month. I haven't seen quite that good of results. Men get closer than women. Women are usually like 15 to 20 pounds, and men can be anywhere from 18 to 25. I don't see a lot hitting the 30 mark every time.
Right, and my experience with it, and the Riordan Clinic, we've been involved with HCG probably, I was looking back in this particular slideshow, which I kind of found reminded me that there was a period of time when I was very actively involved with HCG, and it was through HCG that I was able to, I was stuck at about 210, 212 pounds, and that was the beginning point of where I was able to get unstuck, because I think a lot of people, when they struggle with their weight, there's a kind of set point that no matter how hard you try to exercise and reduce your dietary intake, it seems like you can lose the weight, but what happens is it slows the metabolism, and as you go off the diet, this is what I tell people, is that there's a psychology about dieting. You go on diets, and if you can go on, you go off. And when you go off, that low metabolic rate kind of dooms you to regain the very weight that you had lost. And many of my patients who have struggled with this, I'll ask them, well, how much weight have you lost? And they'll say, oh, about 700 or 800 pounds. And I'll say, what? And I'll say, over the period of losing weight, regaining it and more, and losing weight and regaining it and more, I've lost about 700 or 800 pounds, but I've never been able to keep it off, which tells me that we have not targeted the correct reason for why people have weight gain in the first place. And so I think the HCG diet, it's really not a diet, the HCD program did do some things that we're now beginning to clarify, that at least for me is helping me understand how people can lose weight and maintain their weight loss without having to fall back into the old regain tendency. But it's interesting, when you look at what HCG does, it really does help with hormonal factors. And so hormones do seem to be a part of the equation. In men, I know you can use HCG as a testosterone replacement therapy, and many of the men that I have worked with have told me how much better they feel when they are on the HCG program. They kind of hate to have to go off it. And for women, you get kind of a pan, meaning all of your hormones seem to blossom a little bit more, similar to when a woman is pregnant. A lot of women that I've talked to said, hey, one of the best times of my life is when I was pregnant, except for the very end when I just got so heavy with the baby and everything and having the baby. But really that mid-frame of pregnancy, midterm, there's a lot of energy, a lot of hormonal activity, and so hormones kind of recreate that youthful energy that so much of us need in order to stay active and to stay on a path. But just I was wondering your thoughts on HCG itself.
I think it is good. It does stimulate gonadal, whether it's ovary or testicle. It supports hormone levels. But as aging occurs, you unless you take HCG from an external source, then you lose production of that, just like you do all the other hormones. And I like HCG. I've used it. I use it in men sometimes that may not be candidates for testosterone replacement, to see if we can enhance their levels by giving HCG. Actually, sometimes I use a medicine called Clomid, which is used in fertility medicine, because it stimulates more estrogen, more testosterone, because of the signaling hormones that it triggers off, FSH, follicle stimulating, and luteinizing hormone. But Clomid does similar things that like HCG does in triggering off those signaling hormones to increase output and production.
I think one of the reasons why HCG has not been well received by the medical community is because it is such a low-calorie diet, the so-called starvation diet. And what we are now starting to find that is fascinating, thanks to Dr. Jason Fung, who's a nephrologist, he has reintroduced the concept that many of the myths surrounding fasting are just not true. That when you fast, if you look at the HCG program, it's 500 to 800 calories
Usually his protocol was 500 calories a day.
So people are put on a 500 to 800 calorie starvation diet. And back 10 years ago when I was talking about this, I was still pretty much set that it was just doing something magical to the set point within the hypothalamus, and that was somehow getting the body to burn fat. But the magical thing that happens with fasting is that you deplete your liver's glycogen reserves. And as long as you have glycogen in the liver, and the liver is releasing glycogen, which gets converted to glucose, your body's going to be making insulin. And insulin is the body's fat storage hormone. So as long as you have insulin there, you cannot get to your fat stores. So I think what the HCG plan, Simeon, what he found is when you get people way down on their calories and you give them some HCG so they feel halfway decent while they're on this very low calorie diet, they reduce their insulin levels enough to where they can start burning fat. And so there's actually, I would say, a modern interpretation of HCG that really explains a little bit better why it works. I mean, 3 components of HCG, people feel better because of the stimulation of the hormones, and people feel better because they are now burning fat. And when you're burning fat, you have a more level intake of energy, whereas when you're burning sugar, you're on this roller coaster ride, up and down, hypoglycemic episodes, wanting more carbs, not able to really control your appetite, whereas when you're burning fat, you don't tend to be as hungry. And so if you've got good hormonal support and you're getting into fat burning, you're going to feel better. And so I think this is one of the reasons why the HCG program has been successful.
I agree. I really like the idea. A gentleman a couple of years ago, he came out with a plan called mimicking fasting diets, and basically it's a controlled intake of between 500 and 700 calories a day, and you do that for a week, and then you go back to your more traditional dietary plan for the rest of the month. But you do that for several months in a row. So I kind of incorporate a form of intermittent fasting by trying to stage when people eat during the day. Because if you can stage things that you don't eat before 8 o'clock in the morning and you never eat after 8 in the evening, well, that leaves a 12-hour window that you're basically fasting. And most of it's being done while you're asleep. And that makes a significant difference on the liver, glycogen, insulin, and glucose. So I like trying to incorporate some form of intermittent fasting into a dietary protocol.
And then there's one other element that Mike has introduced that I have not done, and I think it has merit, and I'm going to let you just tell them about it, is the medically supervised approach where you're using a medicine that stimulates adrenaline as a way of helping people avoid the dips that go along with weight loss.
Yeah, unfortunately, the pharmaceutical world has so many products, but in the weight loss arena, it's been kind of dismal. Not many of the drugs that have come out have been very successful in helping people lose weight.
Keep it up to your mouth.
Okay, yeah. Sorry. But one that did come out early on was a medicine came out under the name Fastin and Adipex P. The chemical name was phentermine. And conventional medicine, for some reason, a lot of physicians, I don't know, for some reason they thought it was bad. And I'm not quite sure. But they're the same physicians that also write lots and lots of scripts for Percocet and Lortab and pain management and all of that. Phentermine is in a Schedule 4 controlled class of drugs, not because of addictive issues, but because it's because of the way it can stimulate and improve your focus and clarity, that it's It has abuse potential in college populations that wait till the last week to study for their whole semester exam. And that's kind of the mechanism of action, how it works for weight loss. Sympathetic stimulation, that's the fight or flight mode of the central nervous system. The other one is the parasympathetic, that's the housekeeping, spa, tranquility side of the equation. But in sympathetic stimulation, this fight or flight mode is triggered off, and it suppresses appetite, because the last thing you want to do if you're getting ready to fight or run for your life is sit down and eat a meal in the middle of that. And the other thing it does is it does increase your clarity and focus, and gives you more energy. All of those things are conducive to fighting or running and survival. So the drug works on that mechanism. It's called a sympathomimetic. So it's mimicking the effect of adrenaline on the sympathetic nervous system of the body. So coupled together with a calorie-restricted dietary intake and encouraging more daily physical output, and I try to stay away, I either say physical output or activity, because some people still think that exercise is a nasty word. And so, movement, activity, I encourage steppers, just even as a start. If people they think they're getting up and walking around a lot, but if you don't actually have some mechanism to track your movement, it's impossible to know how active or inactive you are. National polls done on the population, when they ask them a couple questions, and almost universally they will say they eat less than they really do, and they say that they're much more active than they really are. And there's no way to gauge that unless you have some way to measure it. And so I try to set up, when I work with patients in weight loss, measurement systems so they can actually have a concept. Am I really being active? Am I really standing up 12 times a day? Am I achieving a certain goal of steps or distance? And the same thing on the dietary side. I mean, the dietary plans are supposed to give you some insight on a new approach to food groups, portion control, timing of the day of consuming foods, and putting that together and using phentermine. It's not meant to be used long term. It's considered a short-term adjunct to weight loss. The PDR, physician's desk reference, doesn't really define short-term adjunct, but a lot of people think 3 months. I will use it 3 to 5 months. I rarely let anybody go past 5 months without having to stop for a while, because it has the body develops an accommodation to the drug, and after a while it no longer has an impact or an effect. So you have to withdraw from it for 2 to 3 months, and then it's like your body forgot it was ever on it, and then you can come back and reuse it if they haven't met their goal, their weight loss goal. But it's not intended for long-term use. Some of the newest one that's come out is called Contrave. It's a combination of 2 medicines, naltrexone, that's used for narcotic drug withdrawal, and the other one is buspirone, Wellbutrin, that's used for anxiety and that. So one of those drugs attacks award centers in the brain, and the other one attacks appetite, craving centers in the brain. I was really hopeful, because it was approved for long-term use, that it might be beneficial, but I've had a really hard time. A lot of people, the headaches, nausea, and vomiting are in the top 5 side effect profiles. And remember, in side effects on drugs, the most common reoccurring side effect is first place. And then it works its way down the road. So when you have headaches, nausea, and vomiting in the top 5 positions, I have a lot of trouble with people staying on it. And the only reason I'm saying all that is one of the reasons I've stayed with phentermine, because for the most part, 75 to 85% of everybody that uses it is successful. But the other thing I tell patients, it's not just the amount of weight you lost. If you have a journey that you're going to take, it's not so important maybe the destination point as it was paying attention to the journey itself. And destination being how much weight did I lose? The journey, did you learn anything about your activity patterns, about your dietary preferences, and making changes that can become a permanent part of your lifestyle? Because if you can incorporate something as a part of a permanent lifestyle, then you're always going to be on the yo-yo up and down and all around. So.
Okay, we're just about ready to open this up to some questions, but I just can't bear not to at least kind of convey to this audience my excitement, because I really see that there are 5 major trends converging here that I think will help people to finally be more successful in weight loss. Number 1, this adrenaline and norepinephrine are necessary for your mitochondria to make energy. And I wish we could pop that on demand. Well, I think the phentermine does that. I think phentermine gives people an immediate boost of symptomatic effect, which turns on their mitochondria and they have more energy, which is great. But if you can channel that energy into intermittent fasting, which is what the HCG diet was all about. It was about 500 to 800 calories a day, and exactly what Mike was talking about, compressing your eating of a smaller amount into a smaller amount of the time. So your bigger amount of the day, you're fasting. When you're fasting, you're going to deplete your insulin reserves. And as you deplete your insulin reserves, you're going to start accessing your fat. And as you get into fat, the ketones are going to really help your brain work better. That to me was the big plus of intermittent fasting, is that like my brain woke up. Glucose makes me sluggish. Fat makes me clear-headed, and I can stay with it. So, and then now you can start, in addition to that, if you do the HCG, now you've got the hormonal support, because so many people who have been overweight and struggling with it, their adrenals are tired, they're not sleeping, there's no motivation. So if you get the feeling younger again, having that hormonal support, now you've got 3 elements. If you go ahead and start exercising and eat the right kinds of foods, not necessarily ketogenic, but at least lower glycemic, real foods, good fats, high quality proteins in small amounts, you're not going to get sick. So we've got right food. Then the last component would be the interval training. The interval training and exercise is where you do bursts of exercise followed by slowing down and recovery. So this is what's called hormesis. So this new type of exercising could be, I think, a tremendous way to get the mitochondria working together again. So food, exercise, energy, hormonal balance, and clear-headed thinking, on this whole process. Yeah. The intermittent fasting thing, the stable fat, is to me a really exciting opportunity now where people can finally have some permanent success in this area. So with that little overview, are there any questions?
So do we use for HCG, do we use the shots or what kind of ones do we use?
So the question is, for the HCG program, what do we use? We have the shots. They're a sub-Q shot that's very easy to administer using an insulin syringe. You can do it either in the abdominal area or in the front part of the leg. We have intranasal for people who just can't bear the idea of doing the injection. The homeopathic, which I actually had a lecture on homeopathic HCG, and I'm not sure how much that actually works. We have not really done any research here at the Riordan Clinic. But the main 2 would be the injectable and the intranasal.
And I think they also.
Good.
I think they also can do sublingual drops.
Yeah.
Sublingual absorption. When I do hormone replacement, one of the modes for women is very fast. You can't say that you might not swallow a little bit. but the absorption is rather quick. That's why anybody having heart pain, put a little nitroglycerin under their tongue, and 3-4 seconds, it's relieving the chest pain. I mean, that's how fast and efficient sublingual is. So I'm not against sublingual administration for those that don't like the little pointy needles. Owie.
Yes.
Would you explain a little bit about the process of your weight loss program if you want to start that or finish that? What are the steps? What do you do?
Well, the whole concept on medical weight loss is that actually, it's an organized, controlled, under direction program, and it starts first with an intake process. Coming in, I mean, it's pretty much like seeing a physician about your past medical history, about dietary preferences, about medications you're on, because many medications can set you up for failure in weight loss. Blood work that specifically is looking at nutrients, because you can't perform physically at the cell, tissue, or organ system level if you don't have adequate cellular nutrition and cellular energy, the whole methylation process and stuff. I mean, you have to have essential cellular nutrients in order to physically perform. So the lab is kind of important and usually is incorporated in. And I like to look at hormones. It depends on the age of the person. If you're in your late 30s, 40s on, it's probably fair game to, like in women, look at estrogen, progesterone, testosterone, and an adrenal hormone called DHEA. I like to look at cortisol levels because sometimes if cortisol levels are chronically elevated, that can be set you up to trip and fall on the weight loss front. So anyway, looking at essential hormonal function, and yes, women have testosterone. It's pretty important. Remember that whole anabolic phase of renew, grow quickly, renew, restore, rebuild, regenerate. That's all androgen driven, and that's androgen hormones are estrogen, progesterone, testosterone, DHEA, human growth hormone. Those are all rampant in your youth and development years, but they all come to a halt at about that, just on the other side of the downside of that bell curve I was talking about earlier. So looking at hormones, looking at blood chemistries, that's just the stuff a regular doctor would do once a year anyway. To make sure your electrolyte balance, I like to make sure that magnesium levels are good. The Life Extension Foundation at the beginning of this year put out an article that's saying that magnesium may be becoming the next D3, meaning that D3 is, if you don't know, is pretty much epidemically deficient in the population. And I can't get over so many conventional medical practitioners or people that write articles that say it's not necessary to check D3 and that it's okay to, the reference range for D3 is pretty broad, 30 to 100. And it's okay if you're 30 or 32. Well, we don't agree with that. We think you need to have much higher levels than that because it's actually 25-hydroxy D3 is a prohormone. So there's three, D1, D2, D3. But D3 is extremely important functionally inside your body. It's one of the things that supports your immune system dramatically. And it also supports people that have thyroid issues or autoimmune disorders of the thyroid, like Hashimoto's. So looking at all those things, health history, family history, health behavior, risk behavior, and then collectively come to an agreement based on all the information that's collected to put together a dietary platform that's specific for you. Because I think it should be individualized and it should be specific to that person instead of some kind of a canned approach. And then we set up a program. Usually I see patients back monthly. There is a little bit, depending on the length of time you do the HCG protocol, because there's a 20-day and a 40-day protocol. Sometimes the visits are a little more frequent. But usually once a month to assess success or failure, and if there's failure, why, and how are we going to change that. And then just progressively move forward. And it's actually been very effective. I have patients that have lost a lot of weight, and no, they haven't all gained it back. I mean, the goal is to lose the weight and try to then maintain that weight loss. Even though you may not have achieved the exact weight you wanted, if you can achieve sustaining the weight that you did lose, that's a hallmark, big impact. And the weight issue is important. I mean, if you look at the top killers, cardiovascular disease, stroke, hypertensive disease, diabetes. Diabetes is horrible. I mean, it is like an inflammatory forest fire inside the body. It damages everything. And they talk about blood pressure, but the true value of controlling blood pressure is the damage, if it's not controlled, that it does to the vascular wall. It ends up leading to rigidity and hardening of the vascular wall to where it no longer has elasticity and ability to expand, contract, relax. The old lay term is hardening of the arteries. The more medical term is arterial sclerosis. As compared to the cardiologists that go in and balloon and open up arteries, that's atherosclerosis. That's actually the accumulation of debris on the inside the lumen of the artery that narrows it down and includes blood flow. So